All right, thank you for that introduction. And today I've decided to focus on bladder cancer because of all the new exciting drugs that we have for this disease state. For the objectives of the presentation, I'd like you to be able to understand the general treatment modalities for patients with bladder cancer, especially in the metastatic and locally advanced settings. I will also be diving into specific toxicities of these medications and initial management of them. To give a brief overview of bladder cancer, it is the 6th most common cancer in the United States and the 4th most common in men, with a 5-year relative survival of about 78%. However, this does drop drastically in the metastatic setting to 18%. Thankfully, most are non-muscle invasive at presentation, meaning that the tumor has not yet invaded the muscle of the bladder. Most in the United States, 90%, are urothelial, also known as transitional cell histology. Major risk factors for the development of bladder cancer include smoking, as well as certain occupational exposures, like to certain chemicals, like aromatic hydrocarbons and diesel exhaust. This is a sky-high overview of the treatment of bladder cancer based on its initial presentation. For non-muscle invasive disease, the TURBT, which is the transurethral resection of the bladder tumor, both diagnoses and treats the early stage tumor. Intravesical therapy is often given at this stage with BCG or mitomycin, for example. Cystectomy is done for select patients. In the muscle invasive setting, several different treatment modalities may be done. Most patients receive neoadjuvant cisplatin-based chemotherapy followed by cystectomy. Some patients may receive definitive chemoradiotherapy, and newly, some patients qualify for adjuvant immunotherapy, which I will talk about shortly. In the metastatic setting, especially for more distant disease, systemic therapy is the main treatment modality that we have. Now I'd like to focus on some of the new drug approvals that have just been in the past several years that are really exciting. Nivolumab has been approved in the adjuvant setting now in 2021 for patients who are at high risk of recurrence after their surgery. Enfortumab vedotin is an antibody drug conjugate that is approved in the metastatic setting. And just on April 3rd of this year, the combination of enfortumab vedotin with pembrolizumab was approved for certain patients in the first-line setting. Sacituzumab govitecan is also an antibody drug conjugate used in the metastatic setting, and erdafitinib is an oral agent. Of note, gene therapy is up and coming as well, and there's a new approval that I will not focus on today. That is adstiladrin, which is used for non-muscle invasive disease for patients who are BCG unresponsive. Let's dive into immunotherapy now in the adjuvant setting. Nivolumab and its indication is specifically for patients post-cystectomy. These patients have high-risk pathology, meaning T3 or T4 disease, the tumor has invaded certain parts, or lymph node positive disease. These patients may have received neoadjuvant cisplatin-based chemotherapy or not. Its mechanism inhibits the programmed death receptor 1 pathway. So we know that we're going to get a stimulation of the immune system, and that produces its anti-tumor effects. The duration of treatment for this indication is 1 year. The approval for nivolumab for this setting specifically is based on the CheckMate 247 trial, which was a double-blind, multi-center, phase 3 randomized control trial, including patients with muscle-invasive urothelial cancer after receiving a cystectomy and had negative surgical margins. The patients were receiving either nivolumab every 2 weeks for up to 1 year or placebo. They were able to include 709 patients, and they found a median disease-free survival of 20.8 months in the nivolumab group versus only 10.8 in the placebo group. 75% of patients in the nivolumab group were alive and disease-free at 6 months versus only about 60% in the placebo group, and these benefits were seen regardless of the patient's PD-L1 status. This is certainly not a comprehensive review of the treatment toxicities of nivolumab, but I focused on some of the more common and prominent ones that I know have already been mentioned today. Dermatologic toxicity is one of those that can be seen earlier on after starting immunotherapy, with a median onset of 2 to 6 weeks. Most of the other toxicities can be seen later than that, but I've intentionally left the onset range broad here since we can see them early on or much later on in the treatment course. For dermatologic toxicity, for initial education and management of these toxicities, especially more mild to moderate derms toxicities, topical corticosteroids can be utilized along with antihistamines and systemic corticosteroids for more severe toxicity. Diarrhea or colitis was in 17% of patients in the nivolumab group in the Checkmate 247 trial. And this can have several implications for the patients, and we definitely need to be educating them initially before they even receive the treatment about optimizing hydration, diet modifications, and implementing loperamide as the first-line therapy. Of course, for more severe manifestation, again, systemic steroids may be needed. For hepatitis, this has an average onset of 8 to 12 weeks. It's important to make sure the patient is also not on other hepatotoxic medications like Tylenol, statins, alcohol. Thyroiditis is fairly common as well. Usually presents as hypothyroidism, for which we would need to start the patient on levothyroxine. Pneumonitis is a more rare but certainly serious side effect of immunotherapy, and it can present at a wide range, weeks to months into treatment. And usually with symptoms, the drug may be held and systemic corticosteroids may be needed as well. Let's dive into the first antibody drug conjugate that I want to talk about today, enfortumab vedotin. It has 2 indications now for bladder cancer. Its first approval was for the second-line setting for patients who previously received platinum-based chemotherapy and immunotherapy. It also has a new indication in the first-line setting for patients who are cisplatin ineligible, and a lot of bladder cancer patients are ineligible for cisplatin based on their comorbidities. It has a unique mechanism of action. It actually is an antibody directed against Nectin-4, which is a tumor-associated antigen that is highly expressed in bladder cancer. Upon internalization, it releases a toxin, MMAE, which is a microtubule disrupting agent that leads to cell death. And of course, this treatment would be continued until progression or unacceptable toxicity in the metastatic setting. The approval for enfortumab vedotin for these indications is based on these 2 trials. For the EV301 trial, this was in the second-line setting, and it included over 600 patients, and they were randomized to either receive enfortumab vedotin or single-agent chemotherapy. The overall survival was longer in the enfortumab vedotin group at 12.9 months versus only 9 months in the chemotherapy group. The trial on the right is a combination with enfortumab vedotin with pembrolizumab. This was a phase 1b/2 trial, so it only included 45 patients. They found an impressive overall response rate, though, of over 73%, and 15.6% of those patients actually had a complete response. They also found a median overall survival of about 26 months, which certainly compares very favorably to our other agents that we use. This is an overview of some of the more common toxicities of enfortumab vedotin as seen in the EV301 trial. You can see that peripheral neuropathy is fairly common in about 1/3 of patients, but thankfully this is usually reversible upon discontinuation of the drug. We can also see dermatologic toxicity quite a bit, pruritus, maculopapular rashes. We can see GI toxicity with diarrhea in 1/4 of patients. We can also see some cytopenias like neutropenia and hyperglycemia in 6.4% of patients. To delve a little bit further into some of these specific toxicities, this does have a black box warning for dermatologic toxicity, which may occur in up to 47% of patients receiving enfortumab vedotin. That's probably because Nectin-4 is also expressed in certain normal tissues like the epidermis and sweat glands. This may present in a variety of ways, but usually is an erythematous presentation, might have pruritic papules involved. And in very rare cases, you may see things like SJS. For prevention and management of this toxicity, I'd recommend starting barrier creams up front, like zinc-containing agents, as well as protecting yourself in the sun using sunscreen is essential. For management, standard things like topical corticosteroids, antihistamines may be used, silver sulfadiazine, and even antibiotics if necessary. Hyperglycemia is a unique side effect. It's not really known why enfortumab vedotin causes this, but for this reason, it is important that all patients have a baseline A1C prior to starting the treatment, and the drug does need to be held if the blood glucose is ever 250 or higher at any time. For ocular toxicity, this is also a unique side effect, may present anything from dry eyes to blurry vision to things like keratitis. Patients should start artificial teardrops to prevent some of these side effects, and it's actually recommended that patients do not wear contacts on this drug because that can also increase the risk of keratitis. Pneumonitis is a more rare side effect, but occurred in about 2 to 4% of patients, so if the patient is ever presenting with symptoms like a new onset shortness of breath or a dry cough, the provider shouldn't be notified and the treatment may need to be held. Let's dive into our second antibody drug conjugate that I'm going to talk about, sacituzumab govitecan. And this has only approval in the second-line setting for locally advanced or metastatic urothelial cancer patients who have, again, already received platinum-based chemotherapy and immunotherapy. This is an antibody drug conjugate, once again, but it targets something else. It targets TROP2 this time, which is a glycoprotein that transduces an intracellular calcium signal. And this is overexpressed in bladder cancers. It releases a toxin, SN38, which is actually the active metabolite of irinotecan as well, and it's a topoisomerase 1 inhibitor. The approval of sacituzumab govitecan was based on the TROPHY trial, which was a phase 2 multi-center trial, including 112 patients, and these patients received the drug IV on days 1 and 8 every 21 days. You can see the graph on the right here shows the overall survival on the y-axis and months on the x-axis. They found a median overall survival of 10.9 months, which definitely compares favorably to our historical controls, where you would usually be using single-agent chemotherapy, and you have a median overall survival of about 7 months in that setting. The response rate was found to be 27.7%. Main toxicities of sacituzumab are listed here. Dose reductions were more common for things like neutropenia, fatigue, and diarrhea. This makes sense given that we are giving the active metabolite of irinotecan. You can see that 10% of patients experience grade 3 or higher diarrhea, and a good portion also experience grade 3 or higher neutropenia. These are some of the more interesting side effects. The neutropenia has a black box warning for sacituzumab govitecan, but it's classified as intermediate risk for febrile neutropenia, and so you don't necessarily have to use growth factor up front right away, but it may need to be added. This toxicity is more common in patients with a genetic alteration in the enzyme UGT1A1, so if they're homozygous or heterozygous for this, they have a higher chance of experiencing neutropenia. However, at this point, it's not necessary to screen patients prior to treatment. It is a high emetic risk drug, and so I do recommend starting a 4-drug prophylactic regimen up front for these patients. Diarrhea is also a common toxicity, makes sense given that we're giving the active metabolite of irinotecan, and it's associated with cholinergic responses like abdominal cramping, salivation, and we can consider the use of atropine. Infusion reactions were seen in about 35% of patients, so it's recommended to pre-medicate with diphenhydramine, famotidine, and acetaminophen. Now, finally, I'll move on to the last drug I want to talk about, which is the only oral drug I'm mentioning today, erdafitinib. And its approval also is only in the second line for patients who have progressed on or after platinum-based chemotherapy and immunotherapy. Its approval was based on the BCL2001 trial, which was a phase 2, and they found a response rate of 40%. The tumors have to express an FGFR 2 or 3 mutation or fusion in order to receive the drug, because this is an FGFR inhibitor. It leads to decreased FGFR signaling in the targeted cells and thus decreased cell viability. And of course, it would be continued until progression. Erdafitinib dosing is unique. You start at 8 milligrams by mouth once a day, but that is escalated to 9 milligrams once a day between 2 to 3 weeks, but only if the phosphate at that point is less than 5.5. You can take it with or without food. I've listed some of the more unique toxicities on the right in the chart. About a quarter of patients are going to experience ocular toxicity, including dry eyes, but also a unique side effect of retinal pigment epithelial detachment. So if the patient is complaining of blurry central vision, that can be a warning sign of this. Thankfully, usually it is actually a reversible side effect. Most patients do experience hyperphosphatemia. A good 76% was seen in the trial, and so lab monitoring is needed. The patient may need to restrict their oral phosphate intake as well, and we may need to use oral phosphate binders. Finally, dermatologic toxicity is also a prominent side effect in almost 3/4 of patients. So most patients will experience this. They can experience anything from nail changes to hand-foot syndrome to maculopapular rash to dry skin. So all the initial management education should be given to the patient on these things, such as using gloves, avoiding excessive friction, using topical emollients, and topical steroids if necessary. So to summarize, treatment options for advanced urothelial cancer have expanded significantly in recent years. And because of that, we've seen an improvement in overall survival and response rates. Antibody-drug conjugates and FGFR-targeted therapy are new treatment options that have distinct mechanisms of action. However, they come with distinct toxicity profiles as well, and these need to be monitored diligently. These are my references. Thank you.
Do we have any questions?
For the last drug that you were just going over, thank you very much for a great presentation. The erlotinib, you mentioned it has like a specific target that it's directed against, and you mentioned testing. Is that an NGS test? How are you doing that?
So the FGFR mutation, I think it can be NGS, but it would basically be on the tumor pathology and doing a molecular test specific for FGFR for that drug.
Any other questions? Okay, thank you.
Thank you.